before we start the session, I would like to congratulate President PES, Scientific and Organizing Committee on arranging such an excellent program, covering every topic so comprehensively and involving both international and national speakers. It was a great learning experience. Our tonight's session is on diabetes and cardiovascular disease, which is collectively comprised the largest cause of mortality and morbidity in people with diabetes. Our chairperson for tonight's session is Professor Dr. Abdul Jabbar. Professor Jabbar has been associated with Aga Khan University Karachi Hospital for more than 20 years. He worked as professor of medicine and head of diabetes and endocrine section, and now as a visiting professor. He is currently working as consultant endocrinologist and diabetologist at Northwest Clinic and Medcare Hospital in Dubai, UAE. He has been actively involved in the field of diabetes and endocrinology, and he was the founding member and president of Pakistan Endocrine Society. So, you're starting
Thank
remarks.
you, Amna. Thank you. And I welcome you all and very grateful to both the great friends as speakers and the old-time colleagues. We've been still working together as panelists. Today is our last session and we are going very well in terms of all the sessions which have taken place. The last but not the least is the one which is most important, and just to mention, one of the most fatal as well. We see so many of the patients with diabetes, and then now, as we know, the new guidelines also focus on the atherosclerotic disease and the heart failure. And two of my great friends, the very authorized persons in the field of heart, cardiovascular disease and heart failure, are kindly here to give us the important practical insights into that. So I'll hand over to Amna again to introduce our speakers, and then we are on the go. Thank you.
Yes, we are delighted to have with us Professor Syed Zahid Jamal as our first speaker. Professor Jamal has been integral part of NICVD team since 2001. He is Diplomat American Board of Internal Medicine and American Board of Cardiology from New York and Boston respectively. He further proceeded to receive his fellowship in electrophysiology from Harvard University, USA. Tonight, he'll be discussing the dilemmas and conflicts in diabetes and CVD. After the talk, we'll have our question and answer session, and you can write your queries in the chat box. And for the panel of experts, we are honored to have with us Professor Saeed Mahar. Professor Mahar is currently working as Professor of Medicine and Consultant Endocrinologist and Diabetologist at NICVD. He is CPSP Certified Fellow in Internal Medicine and has also completed a fellowship in Diabetes, Endocrinology, and Metabolism from Aga Khan University. He is also a Fellow American College of Physicians and Fellow American College of Endocrinology. He has served as president of PES, and he is regarded as authority in the field of endocrinology. Our second panelist is Dr. Qamar Masood. He is Associate Professor Endocrinology at Aga Khan University, Karachi. He is Diplomat American Board in Endocrinology, Diabetes and Metabolism. He is Diplomat American Board of Internal Medicine, and he is an eminent endocrinologist and researcher. His research is focused on diabetes and cardiovascular disease, both from primary prevention perspective and improving the clinical care. So I would request Professor Zahid Jamal to start his talk.
Okay. Assalamu alaikum, everybody. Can you hear me now?
Yes,
okay,
sir. Perfect.
Good. All right. So, okay. Thank you very much. Sorry, actually, for some reason, I had 3 talks today, fortunately or unfortunately. I started at 7 in the morning, so I'm all lost. So I thought it was 9:30. My good thing Jabbar reminded me. I thought so. I was just finishing up final touch on my slides, but let's see. So without any much gap, I will start. This is a big topic, and Jabbar gave me a real challenging and conflicting. I don't know. Is my class okay, whether I was not good to him or why he choose this topic, a difficult one, where the data is all on air. People have started understanding this is a real conflict, and there are more challenges in understanding diabetes. Every time we hear new guidelines, new concept, new approach, okay. So I will try to make it simple the way I try to understand. Uh, I will go through it, okay. So, sorry, my laptop today looks like it's tired. Let me see if I can move to. All right. I mean, the first slide, as you can see, is a case of a 46-year-old male. I mean, obese BMI, markedly obese BMI 42. Okay, with little troponin leak, CK was high, as a dyslipidemia, smoker. You know him. It's more like a typical American. Okay, I mean, so this type of patient, when you do the ECG, come in the emergency with MI. Okay, I mean, before even taking this patient to the cath lab, okay, I know, the first thing I know, this patient has all the major risk factors. And this case is, you can, when we did the angiography, you can see the patient has critical left LED disease, which you can tell from the ECG, nothing surprise. But what other problem with this angiography is, we know just by looking at the risk factors, the patient may have diffuse disease, okay? You know, when we do angioplasty or revascularization, we can only do the spot treatment where the lesion is, where the green arrow is on the left, you can see, and the circle. We can fix this problem. What will happen to rest of the vascular, the anatomy? Okay, they have diffuse disease, they have little problem. So many times with gross angiography, you may not be able to understand the atheroma burden of this young man. I mean, 46 is a young male in US, okay? They could not even define what's the elderly. Their president is now 77, 78-year-old. He's contesting for and he's a future president. So you can understand how they define young, middle-aged, old, and elderly, okay? In Pakistan, after 60, they call you old, okay? So, all right. In any way, so you can see the burden of atheroma. What we do, there are different ways of doing OCT, I don't know, and intravascular ultrasound, and we look into burden of the atheroma, which can tell you how much diffuse atherosclerosis this patient, which may not be appreciated just on gross angiography. Now, the problem with, you know, the WHO, we have been looking to patients, they are predicting the millions of patients are going to suffer. It is rising from 1980. They have been predicting every time until 2014. It is increasing in middle class and lower income countries, like we are the one who are, and they're projecting more for 39 million when you hit for diabetes. So why I'm going through it, to understand how severe disease it is. I mean, and why I'm talking about, looks like our business for cardiologists is bright, okay? It's not good. As a doctor, we should not say that, but we know. So diabetologists and cardiologists, I mean, they have a future. At least you can see that with all this production. Now, sorry, I mean, half of my screen is covered, so sorry. There's much advanced. At the same time, the good story is people are living longer, okay? And prevention, before there was no concept of prevention. It's still not here in our part of the world. The cardiovascular mortality is very high, but people are living with it, okay? They get the treatment, people have started walking, watching their diets, they're getting better drugs. We have statins, we have better anti-diabetic drugs. I mean, people are specializing in endocrinology and they're followed by specialists. So, I mean, they are getting better care and people are going to see more and more patients with complications who are living now, okay? So this is another challenge for cardiologists because these are the patients who are surviving with the better treatment. Although we know that it's a leading cause of morbidity and mortality, and indirectly it's going to increase the cost. The other question is, we are not can't look at the patient just is the patient is diabetic. You have to know that patient have other, very few patients diabetic have isolated one risk factor. They have always one or two additional risk factors. Of course, you have to coexist. More commonly is hypertension, dyslipidemia. So what to do about it? Somebody who comes to my clinic, I always have medical students in my clinic. First thing I gave them, load your, in the app, the ASCVD risk calculator. Okay, I can't tell this patient whether he needs an aspirin. I can't tell this patient whether uh, uh, I'm talking about just if the patient walks into my clinic and diabetic with no coronary artery disease, how you evaluate, how I decide. I mean, so most of these patients go to endocrinologists, but they refer to me. It's very easy because I know they already has coronary artery disease. So for me, giving aspirin and statin is so easy for me. Few times we come across patient diabetic with no additional risk factor, which is rare in our practice. So, so diabetes itself is an independent risk factor, and so we know the old slides. We know that it's not just diabetes. Okay, impaired glucose tolerance and also IR syndrome. They all have increased risk. So even you can see this is a very nice slide to understand the impaired glucose tolerance. I mean, they are still at a risk. I mean, patient of pre-diabetic at risk. So their normal life expectancy is not the same, even although they may not be diabetic. Okay. And why we are concerned as a cardiologist, we know 2/3 of diabetic die from cardiovascular disease. So what we do, they all end up at in the seeing a cardiologist if they're lucky ones, if they survive, if they many of these patients have silent ischemia. Okay, many, and that can be seen. That's a misconcept. That can be seen also in hypertensive patients. They can also have silent ischemia. So this is a little much of a challenge. So I don't want to go into complication. The risk we all know about. We know the now when looking at the literature is full. Not a single article. I mean, people have so many studies. Now people have started doing, all the studies are designed differently, different clinical groups, different indication inclusion criteria are different. When they did a meta-analysis of all these patients, I mean, with diabetic, fasting, glucose concentration, risk to stratify the vascular disease. Vascular disease means it's not a cardiovascular disease only. I mean, looking about carotid artery disease, looking at the peripheral artery disease. I mean, when we summarize, you can see the patients with diabetes and no diabetes. Okay, the incidence of coronary artery disease, ischemic stroke, everything is high. You're not surprised. This is a meta-analysis of more than 100 trials. And we know from the old trial that established data we have from NEC BP cholesterol data that patient with diabetic, okay, they are being considered already a cardiovascular risk and they are being treated with statins. Okay, we have European guidelines. These are all established data. But the oldest data is of Framingham. Actually, I lived in Framingham in US. Okay, so that was my hometown. My kid was born in Framingham Hospital, so I know where this place and where all the research center is. The good part of Framingham's town was people don't leave that city. They're born there. Their kids are born there. Their grandparents were born there, so they've good track record. So I was involved in many of these studies. It was easy for me. I have to go into the medical record department and then just have to type the disease and you can have their families, the data, everything is there. Okay. And I don't know why I'm the only one. I think I left that town. I came back to Pakistan. But I've heard people who come here, they don't leave. Therefore, they have the strongest data and the center there. So they have a long track record. And what they found, for some reason, I can't take the screen out. Let me see. I'm seeing half of my screen. Okay, now it's okay. So 20 years of the follow-up, or 6% of the women and men, and both they followed up and they found what happened with these patients. Among diabetic women, the incidence of cardiovascular disease was 3 times that among non-diabetic women. So that is the another thing. So women have the higher risk, and so it was learned from this follow-up of these patients. So then there are famous Mr. Fit trial. Okay, I mean, they were looking into patient absolute risk of cardiovascular death was much higher for diabetic than non-diabetic men. Okay, so this was a study for men. Here, they were 3 times higher in patients who were non-diabetics. So we have data for men, okay, only in this trial, and those patients who were diabetic, they were higher risk. Now they came in another big trial. I mean, this was a turning point in cardiology when people have so many data, Mr. Fit trial, the Framingham study, collaborative study, cholesterol data. I mean, this was the first trial which changed the concept. The mortality from heart disease in subject with type 2 was published with and without prior MI. And after this data, they labeled every diabetic is an MI equivalent. It doesn't matter you have coronary disease or not. Okay, you can look into data here into these four groups: diabetic with previous MI, okay, and non-diabetic, okay, prior MI, diabetic with no prior MI. The group with diabetic with no prior MI and diabetic and patient with non-diabetic and prior MI, there was no difference. So they thought, I mean, oh my God, I mean, this is the turning point in cardiology. So any diabetic who walks in, we will consider them irrespective they have coronary disease or not. They have been labeled as, after this nice study published, that they are MI equivalent. What does it mean? You don't have to do angiography to know if somebody is diabetic, you know they have coronary artery disease. Okay, and you know their risk is high. So what you do then? How you control their risk? Very simple. Identify their risk factor and control more aggressively. You give them statin, you give them aspirin, then other controversies with aspirin, statin, everything is I'm going to talk about. Is that true even that all the diabetic have are equivalent to MI? So another data, this is from the cardiology data what we have. The TAMI is a famous trial when we look into patients who present with acute MI and we give thrombolytic and they did angiography on these patients, look into these patients. And the patient with diabetes after MI have a worse outcome, irrespective, okay, if they have diabetic and they are present with ST elevation MI. We are going to know this patient is going to have all kind of complications. They have bad anatomy, they may have multiple extensive disease, and they have worse outcome. So what you do? So I mean the other studies, they did a study in patient detection of coronary artery disease in asymptomatic patients, an aggressive approach in which they looked into patients with no symptoms. And there's a very aggressive study in asymptomatic patients. So everyone was scared that they have bad anatomy, they have multivessel disease, what to do? People started doing angiography on these patients and they were not surprised. I mean, they found they have more severe disease. Okay. And what they found, if they have more than one risk factors or more than two risk factors, did not help to identify asymptomatic patients with a high prevalence and unrelated to more severe disease with unfavorable coronary anatomy. So, so less risk factor, of course, you have less bad anatomy. This is another cardiology trial, the famous Intent Heart trial. Why this trial is important to me? This trial was done in Pakistan and international. So we have few patients from Khan and from NICVD and by Salim Yusuf, who is a famous cardiologist and also epidemiologist. He did this study and I was interested to know because it represented our population of patients. So what they found, these patients, especially in Pakistan, I mean, they have the same risk factors: abnormal lipids, smoking, hypertension, diabetes, obesity, less consumption of fruits, vegetable, alcohol. He looked into what was different in our population, especially in subgroup. And you know what came out again? Sorry, I didn't put all the data here. That again, the diabetes, hypertension, and the other thing, lack of fruits intake and vegetable intake was consumed less in our population, which was very, I was not surprised. People are more, you know, love to eat more of a meat and less of a fruits and vegetable. So this was independent risk factor in our population. There's less consumption of fruits, vegetable, more smoking, lack of physical activity, and again, you're not surprised diabetes and hypertension. So how you risk stratify these patients? Is diabetes really a coronary equivalent? I mean, this is a question. Many people were still debating. Many people did not digest that label because I tell a diabetic that you have a heart disease. Am I justified to tell all the diabetic that your risk is as same as anybody with who had an MI? So many people question that. There's so many studies going on. So they did another meta-analysis, as I told you, because there were independent studies and not one large trial, multiple studies. And what they found, diabetes has not long been considered, we know that, is a cardiac risk factor. After this meta-analysis, the coronary artery risk was 43% lower than when compared to individuals without diabetes with a prior MI. So this was another turning point in cardiology. So, I mean, what we do as a cardiologist, We know, we learned from before, they are high risk patient, they equivalent to coronary artery disease. What this meta-analysis is telling is not every diabetic you can label they have actually, they are less 43% people. Okay, they they had a lower risk than somebody who had an MI. So this is an eye-opening. What to do? What's the message we are getting from this? So it is very conflicting. It's the dilemma, it's a debate. I mean, what to do about all these meta-analysis now? And they did not support the hypothesis that diabetes is a coronary heart disease equivalent. Okay, bad news for cardiologists. Okay, I thought I'm going to get more patients. Okay, and treat them as a CAD patient. But so how to identify which patient you can label as a CAG equivalent? So this is a you can look into the here the third from the top. You can see the graph here. Okay, this is the group of patients who are diabetic, and the one in the middle, the second one with coronary artery disease. You can see, of course, there's difference. Somebody who has coronary artery disease and somebody who is diabetic. So you can see the graph different. It was true in men and women. So this is an eye opening. This clearly tells you that not all the diabetics, okay, they're same risk. Yes, if you're diabetic and you have a coronary artery disease, you are the highest risk. Okay, so you can see the data into all age group. Now, looking into coronary artery calcium score, okay, so how to risk stratify patient? We know they have bad anatomy. So people started looking into non-invasive way to further risk stratify the patient. I think this is very important. The role of coronary artery calcium score in prediction of all-cause mortality and cardiovascular events in people with type 2 diabetes. This is another meta-analysis of multiple studies. What they found, okay, what they found about 28% prevalence of patients with zero calcium score, indicating a similar 5-year survival rate as in patients without diabetes. So, thus, likely the subgroup of patients may be lower risk for coronary artery disease, especially patients who are under 40 years old. So at least calcium scoring, you know, it's a very simple test. Okay, it doesn't take much time. It will, you do calcium and they take your the scanning and they calculate the load of the calcium burden in the coronary anatomy in the different arteries. Zero is a good score. Recently, one of my kids' parents, not my kids' parents, but I'm kids' teachers, they came to me. They want to know what's their risk. And they were asymptomatic. Both are teachers, very active physically. I didn't want to do any tests. I mean, I just straight took the history. They were non-smoker, they were not obese. I know they have been physically active. Only I did want to know because they are above 50, what's the lipids and other thing. And still they were not satisfied with my answer. I told them you don't have to do any workup, just control risk factors. Everything looks good. So we ordered calcium scoring. The teacher, the husband calcium score came out of 30. His wife, his calcium score was 0. So what does it mean? So calcium scoring is a very good way in patient in intermediate risk, okay, or in low risk, but not in high risk. So at least I can tell, I mean, that there's so many data that just with calcium scoring, you can risk stratify these patients that you are low risk. But there's no point in doing calcium scoring somebody who's above 60, or you know that coronary artery disease risk is already high in that age group. Okay, somebody in the middle age has a family history of strong coronary artery disease. I mean, everything looks normal. Patient doesn't have more than one risk factor. You can add calcium scoring because it tells you at least, okay, what's the burden of the disease is. But what else you can do? Even if their calcium score is high, the treatment is not changed, okay? So which you already identify that patient by ACBD risk calculator or uric risk calculator, this patient high risk, still the treatment is same. Even if calcium score would have been 300, my friend's brother, I ordered calcium score. He plays squash and he's very active. His calcium score came on 350, 400. What I will do, he said, somebody ordered him to get his angiography done. to do a stress test them and everything. I said, you don't have to do anything. I know your risk is a little higher than others. Okay, so I have to, what I have to do? Okay, he's a smoker. He has mild hypertension. I'm more aggressive. So I started high intensity, calculated ACVD risk calculated. So it was moderate to high intensity. Statin, I started on him. That's the way you treat. Okay, he was not diabetic. I'm talking about patients who was not diabetic. The treatment will not change. Even that patient could have been diabetic. Okay, irrespective of his calcium score. The only thing that helps in calcium scoring is to risk stratify the patient. How you're going to treat this patient, whether you can start aspirin on this patient or not. There's so many studies. I mean, we know that not every diabetic needs aspirin. If somebody asks me whether I need aspirin or not, I can't tell. I have to risk stratify that patient. Okay, so this can help. So all the guidelines change, like ACC guideline, ADA guideline, Brazilian guideline, European guideline. After these meta-analysis, they no longer consider diabetes as a coronary risk equivalent. Good news for diabetes. Okay, so but not for all the diabetics, not for a message for all the endocrinologists. At least they try to understand not all are diabetic. So it's your job as a physician, it's my job as a physician to label them. They are bad diabetic or a good diabetic. There's nothing like good diabetic, but means low risk. So this is a risk calculator I was talking about. You put their age, gender, race, cholesterol, LDL, blood pressure, systolic, diastolic, where they are taking antihypertensive, they are diabetic, and if they're smoker, and then they calculate the risk. Okay, and then you see what's your risk is. Okay, and then you can aggressively convey the risk of more than 10%. Risk is less than 5%. Is it between 5 to 7%? Is it intermediate risk, low risk, high risk, very high risk? So, and then you can visualize the patient. Somebody who has already atherosclerotic cardiovascular disease, you don't need this calculator. Patient already had MI, patient already coronary artery disease, patient, they have all the symptoms of coronary artery disease, will treat them with high intensity statin, aspirin, and of course, beta, whatever. So these calculator are for those patients who may be low risk or intermediate risk. So you can't be aggressive with your treatment and your approach with the same. You can't use the same machine gun to treat everybody. You have to risk stratify the patient the same way. So screening is very important. So you have to calculate what's your 10-year risk. Is it more than 7.5? European guideline, of course, they have to be different. They didn't want to use the ACVD risk calculator. So it doesn't matter. They have a Euro score to risk stratify the patient with the European high risk chart. Okay, and you can enter all the numbers, and they define differently: very high risk, moderate risk. Okay, now usually young patient is moderate risk if they are less than 50. Okay, and if they're diabetic, duration is less than 10 years. So for an American study, we learned if you're less than 40 years, you're low risk. I mean, you don't need to be aggressive with aspirin and other high intensity treatment. According to European guideline, they think more of a less than 50. Okay, maybe you're at a moderate risk. Okay, but at least we know less than 40 years and diabetic duration less than 10 years of not very high risk patient. So what you do the management when you identify. I don't want to go through it. Of course, what's their recommendation? How to manage diabetes? Did they write it to do angiography? Did they recommend them to do a stress test? Nothing. What you see the guideline is recommending to control all there, whether you have to lifestyle change, control your body weight, control the A1C, okay, and of course not to be very aggressive in very elderly patient, okay, with the fasting glucose, and of course I mean first line of metformin. Now they've included SGLT2 inhibitor. You have been hearing all week all about, even the cardiologists know about this good drug. I mean, so many good news. We have many good other weapons with us how to treat this bad disease. You don't have to use a machine gun. Okay, you can use all your tools, and you have to risk stratify the patient. So in 2013, the ACC guideline, when what they thought, they risk stratify patient with diabetes with ages are from 40 to 75 into two categories using a global risk score calculator. EAC guideline, as I told you, okay, they use patient younger than 40 with a shorter duration of diabetes and Between 40 and 50 is a moderate risk. Okay. So now, if somebody comes to me with a diabetic, so the very things you have to look, does the age matter? Does the gender matter? Does the family history matter? Does the smoking matter? Does the hypertension matter? Does the lipid matter? Oh yes. Okay. Relation between age, okay, men and women in diabetes compared with non-diabetic, you can see another age should be taken into account in targeting of risk reduction. So again, you're young if your age is 40 or younger, okay. So they have taken less than 40, somebody started having diabetes, they consider as a low risk. You can't start them on aspirin or just because they are diabetic. You can't give them high statin, and you can put there on the calculator, they will come on low risk. So you can't be aggressive because aspirin also causes, intracerebral hemorrhage, GI bleed, and many people die. So we learn from all these studies where you have to be aggressive, where you don't have to be aggressive. So gender is also important. Okay, we know that somebody comes with MI, incidence is higher in men than in women, but patient in women, they have higher complication. Okay, due to so this is important. Relative risk for a fatal coronary event is 50% higher than men. Okay, so this is very, if somebody in a women comes into an ICVD with MI, okay, we know. She will have more complication than men. Okay, so data is very strong. Okay, although the incidence in men is higher, but women may have more fatality, rupture of cardiac rupture is more commonly seen, and other complications more commonly seen in women. So we know it's gender does matter. Okay, what about family history? The famous women health study, the MESA study. Oh yes, all these studies have shown it has independent prediction. Those who had 2 or more affected first degree relative, the incidence of coronary artery disease was 79% higher. You don't need any test. You don't need a calcium scoring. Okay. So if they have somebody with family history, means premature coronary artery disease in men before 55 and women before 65. In their 2 or more first degree relatives, that's enough for you to stratify this patient. Family history of fatal, non-fatal coronary artery disease in parents, siblings, okay, and considered as an independent risk factor. So simple. You don't need expensive tool. You don't need expensive tests. If there's somebody is diabetic, very simple. Just risk stratify. The basic medicine, the basic practice, we have to go back again with all these trials are telling us. There are other non-invasive way you can look into, as I told you, like calcium scoring, ankle brachial index, CRP, okay, and again carotid, and again flow mediated dilation, looking for the brachial testing, whether how good their the endothelial function is. The same thing with the screening, with the smoking. If the diabetic is a smoker, okay, does it matter? Oh yes, okay. So I'm not going to go into that. Blood pressure lowering in type 2 diabetes, if they're high risk, if they're more aggressive, after the sprint trial and other trials, why they made the numbers lower, okay? The lower, the better, okay? Again, they're changing in diabetic again, with further studies are going to change. Now, blood lipids, I already told you, you have to risk stratify the patient. Assessment through risk score calculators, I already discussed. There are many, many risk calculators, okay? 110 different cardiovascular risk calculators. The UKPDS, they use a different one. The UKPDS RE, they use different calculator. So risk calculators are done. There are other ways you can risk stratify your patient. Or longer the duration, early diagnosis duration, longer than 10 years can be considered high risk. Low GFR, microalbuminuria, metabolic hyperglycemia, hypo. So these are not have independent risk factors, but they can add to the risk. Okay. Now, vascular disease, and of course we know they did a 2-fold excess risk of diabetes about, all kind of vascular disease. So not talking about just a coronary artery disease. So I told you about calcium scoring. Measurement of calcium scoring in select adults with borderline elevated ASCVD, where the risk is between 5 to 7.4. What you do, okay, whether you want to start aspirin or not, you see calcium scoring is high, patient is in an intermediate drug, then you may consider. So these all can have in planning. So it's more like a tailored therapy. You can't have the same design and clothing and same measurement for all your patients, like a tailor. Therefore, in American words, they love this word. You have to use a tailor therapy. You have to individualize your management and treatment. Aspirin, I already told you about. Again, do not use aspirin for primary prevention adults under 70 years with a calcium score of 0. Okay, regardless of 10-year risk, aspirin appears net clinical benefit in patient older with calcium score more than 100. This is another point where you can justify using aspirin. In high risk, it's easy. Now, again, initiate the statin therapy again with, I already told you, older patient with low burden risk factor, whether they would benefit from high statin. Okay, so you can't be aggressive in all the age group. If they're more than one risk factor, okay, and diabetic, of course, they're going to different class. Other biomarkers. If you're really worried about your patient, you can order high sensitive CRP. Very strong data. Okay, from rosuvastatin trial. I'm forgetting the name, just keeping in mind. Okay, doesn't matter. The Jupiter trial. Yes, they did look into the patients whose cholesterol was normal, men above 40. They did not have any risk factors. If they come to your clinic, what you will do? The cholesterol is fine. They're not diabetic. You order high sensitive CRP, and it has shown in compared to all other markers, there are so many. There are at least 15 markers in novel, what we call novel cardiac markers. High sensitive CRP was the winner, and they showed if your high sensitive CRP was more than 2, they followed these patients and they treated with rosuvastatin 20 milligram, and within 4 years they showed the difference in decreasing mortality. So somebody who walks in your clinic with no risk factor, I order high sensitive CRP, but if it is very high, more than 10, is it also reactant? So you can see in other inflammation, infection. So coronary artery disease also inflammatory disease. It's an infectious disease. Very high sensitive troponin is not a risk factor for coronary artery disease. So you have to understand that. So you can further individualize the patient. High sensitive troponin, oh yes, it can add to your value. Pro-BNP, these are all further markers which can, but the management will not be aggressive. It doesn't mean that you will put them. This is a very nice slide when they combine coronary artery calcium and ABI, high sensitive CRP, family history, independent. You see the graph goes on the left. The most on the top is the calcium scoring, okay, plus the Framingham risk score, when you combine with calcium score, okay, which is more important than just Framingham score alone, then IMT, then looking CRP, then looking into family history, looking into ABI, okay. So this is still, because I told you, because of Framingham risk scoring is still established, because they have the strongest follow-up of the patient and a longer duration. So this is another, I will talk about it. Zero calcium, what does it mean? If you have other ways, if no microbial,
Zahid, we are running short of time.
Okay, all right. I'm just going to finish. Symptomatic patients, it's easy. Do not recommend calcium scoring, of course. You have to treat the patient if they need it. Now coming into stress testing. Which patient need? Of course, if there's symptoms, okay, it's easy. Okay, we know that. But what happened to detection of silent myocardial ischemia? You send the patient for ETT, stress thallium, okay? Now, I will jump into DUST screening for subclinical improve outcome. You see this trial with no benefit. The famous dynamic trial, meta-analysis of all the trials. It doesn't help in decreasing the risk. The risk of MI, heart failure, all cause death, okay? So what's the purpose of the screening, okay? All right, so you can be more aggressive medical treatment to these, offered to these patients. So I will just one line on coronary revascularization. Is that symptomatic and you find they have 3 vascular disease, they always do better with bypass surgery than angioplasty or medical therapy. The Freedom trial, and of course, optimal medical therapy is as good as angioplasty. They don't need angioplasty. It's not going to make them live longer. Okay, the medical therapy and angioplasty is the same. You're just relieving the obstruction. You're not going to make them live longer. So this is a clear message. Conclusion, type 2 diabetes increases cardiovascular risk. It's twofold, we know that. Above 40, we know, I already discussed. More than 10 years, I discussed. And of course, you have to decrease 50% reduction if they're coronary artery disease and LDL, and you can further risk stratify by other non-invasive. I think I will stop here.
Thank you, Zahid. Wonderful. And as we were going through, many questions were coming in my mind, but in the last few slides, you answered almost everything. But I will just, for the sake of time, we'll wait for a couple of comments from my two panelists in terms of we manage diabetes every day. So if they have got any questions or comments before I hand over to my next colleague, Dr. Hani, and then we will take more Q&A session at the end of the second talk as well. So Dr. Qamar Masood and Dr. Saeed Mahar, before we start the next session.
Dr. Qamar Masood here.
Please.
Yeah, very nice talk. Just Dr. Zahid, I want to just ask you, as a treating endocrinologist, diabetologist, sometimes we get very uncomfortable in patients sitting to us who have all traditional risk factors and plus additional risk factors like, family history. We are treating them for everything. I mean, hypertension, dyslipidemia, diabetes. The thing is, what is the role of CT coronaries? Sometimes there may be a soft plaque there, sitting up there, and the patient that is sitting in front of you, you look at him as have all the risk factors for coronary artery disease, and you are afraid that one day it will come as a surprise to him. Is there a role of CT coronaries?
I think it's a very important question. I'm shocked why people even order a CT angiography. Okay, it has a very limited data. Okay, the only time I will order a CT angiography, I will tell you where. If somebody had a bypass, I have to make it sure that their grafts, they are a good test. Look in the graft where they're patent or not. Okay, they have symptoms. That's it. Because coronary angiography will tell you the anatomy. It doesn't tell you the physiology. Okay, why you're ordering coronary angiography? Look at the anatomy. Okay, of the patient.
No, like when somebody who's asymptomatic, yeah. Yes. When somebody who's asymptomatic and maybe a stress testing would be negative. You expect that a stress testing would be negative. There would be not a critical lesion there. But does it help in characterizing the plaque?
No, not at all. First of all, it can't exactly tell you it's an unstable plaque or a stable plaque. Okay, how you can tell somebody has a stable plaque? When I teach my medical students, it's very simple. Okay, I tell them two questions. What is stable ischemic heart disease means? They have a stable plaque. Unstable coronary artery disease, they have unstable angina. So anybody who walks into the emergency room, okay, they have unstable plaque. If there's somebody has symptoms for within 3 months, okay, they are unstable. So I'm talking about patient who has symptoms. Your question is tough. Somebody who's asymptomatic and you want to know they have unstable plaque. Okay, there's no way you can find out. Okay, the only way, even by anatomy, by angiography, by angioscopy, you can't tell. Unstable plaque is a sudden rupture of the plaque. Okay, and patient will have some kind of symptoms. Even in diabetic, either maybe short of breath, new onset symptoms. This month I picked so many patients who were diabetic who just came to me routine checkup. When I asked them, do you have symptoms? Yeah, I used to walk. Now I can't go to second floor. I get short of breath. Many of these diabetics, they are short of breath. They may not have typical angina. That's enough for me to screen them. And I found that 3 vessel disease critical. When I did the angiography, they all had unstable plaque. But the history was within 3 months. If somebody has symptoms, new symptoms, okay, they need to be worked on. Then you are going to do. But CT angiography doesn't tell you stable plaque or not. Okay. If somebody,
Great.
So unstable angina, the treatment is always invasive. You don't do any tests. Stress thallium, ETT, CT angiography are not going to tell you about the stability of the plaque or not. You think it's a clinical history. The patient unstable angina, unstable plaque. Okay.
I will
you have to do.
Yeah,
angiography.
move. Dr. Saeed Mahar, any comments, or Dr. Hani, any comments before we move? And then we'll have some
So, sir,
discussion at the
I
end.
think so.
The
Dr.
challenge of
Syed has very well elaborated all the aspects of the cardiovascular disease in relation to the diabetes, and what we are majority of the time, the 30-40% or maybe sometimes more than that, the patient who has got ischemic heart disease has jointly has got the diabetes also. So I think so. He has very well elaborated all the things. So I don't have got any questions.
Dr. Hani, any comments from you before we hand over to Dr. Amna to introduce you and move forward to the next talk?
I think the comments are all very well elaborated. I think the main thing is that the diabetic have subclinical symptoms. So we have to be very careful. I will discuss this in my talk, but some of these soft symptoms are very important markers because of the presence of diabetic coronary artery disease and diabetic cardiomyopathy. So we shouldn't ignore any symptoms. And I think one of the key points is looking at the ECG in these patients. If the ECG is even slightly abnormal, this is not a normal patient, and they do have either coronary or heart failure. So it's a very challenging thing, and the evidence is really overwhelming about the tremendous risk that these patients have.
Thank you. So Dr. Amna,
Thank you, sir.
move to the next
Thank
one.
you, Professor Jamal, for such a comprehensive talk on this complex topic. Our second speaker of tonight's session is Dr. Hani M. Sabbour. He is consultant cardiologist and electrophysiologist at Cleveland Clinic, Abu Dhabi. He has served as Director of Cardiac Arrhythmia and Electrophysiology at Landmark Medical Center in Rhode Island, USA. Later, he worked as clinical assistant professor, cardiovascular disease at Warren Alpert School of Medicine, Brown University. He is American board certified in internal medicine, cardiovascular disease, cardiac electrophysiology, advanced heart failure and cardiac transplant, echo and nuclear cardiology. Dr. Sabbour has been involved in multiple clinical trials, and he has done extensive research on cardiovascular diseases. His tonight talk is on Journey from Diabetes to Heart Failure, a clinical approach. Over to you, Dr. Hani.
Thank you very much, Dr. Amna. Thank you very much, Dr. Jabbar, and the esteemed faculty. It's really an honor and a pleasure to be part of your very important meeting. And really, I think it's a recognition of now how we can put to help treat these patients with high cardiovascular risk, and particularly the diabetic patient, and beyond that. Start here. So I'm going to focus on heart failure. Since my previous faculty focused so nicely on coronary artery disease. So LT2 inhibitors in type 2 diabetes focus on heart failure. And secondly, heart failure as the neglected complication of type 2 diabetes from prevention to active treatment. So why do we talk about heart failure and diabetes? Because it impacts the survival. It impacts the survival of that. Heart failure is very frequent and prognostically important in diabetic patients. As a complication, observational and clinical trials suggest that heart failure in patients with diabetes is a 4 to 10-fold increased risk in mortality in diabetes. In contrast to MI, the risk of heart failure in diabetics persists even when the conventional risk factors such as hypertension and hyperlipidemia are well controlled. This is the inflammatory diabetic cardiomyopathy. So therefore, it becomes very important to detect the early stages of heart failure in diabetes with mild symptoms that are often missed and will have a significant impact on the treatment of these patients to improve survival. And you know very well that the specific treatments and guideline recommendations for management of heart failure with diabetes and also without diabetes, including RAS blockers, SGLT2 inhibitors, and MRA. So I'm going to start on something that's very important and often missed, and this is actually the Heart Failure Association BNP and BNP in the outpatient setting for diabetologists actually and primary care physicians to detect heart failure. So why is this important? I'm going to just bring your attention to this very large study that was conducted in the UK from the National Health Service, heart failure, and were then admitted to the hospital. They went backwards and looked in the prior 5 years to the diagnosis, 41%, 15,000 patients had a primary care consultation and had some heart failure symptom recorded. Of those, 24% with the recorded heart failure symptoms were actually referred with an echo, natriuretic peptide, or specialist referral. 44% had no echo, NP, or referral at all and ended up just in the hospital. So the conclusion is that very few patients in the outpatient setting, particularly high-risk diabetics, are following a guideline recommended pathway. They are missed late diagnosis, and there's a lot of opportunity here for heart failure diagnosis and escalation of treatment. So some important clinical pearls, and I'm trying to stick to the clinical today, is that heart failure is a very common complication in diabetes. Can be actually up to 50% of diabetic patients, often unrecognized in the outpatient clinic. We can use NT-proBNP or BNP as a very powerful tool to dyspnea, fatigue, lower limb edema, and abnormal ECG. And at this point, a quick NT-proBNP will help you as soon as you're considering the referral to the cardiologist or getting an echo. Finally, these are two very important points. Lower limb edema is never a benign finding in a diabetic patient and should not be attributed to amlodipine in diabetes. It really requires a further workup. And if the NT-proBNP is normal, echo is actually not needed and actually applies appropriate triage and cost saving on need for echo, although this patient may have angina, of course. So the ESC guideline proceeds like this. You look at the probability of heart failure. So some patient with mild symptoms, as we said, dyspnea, fatigue, lower limb edema, exhaustion, history of prior coronary artery disease or revascularization. A diabetic patient with history of hypertension, that's like 99% of our patients. Prior history of drugs or radiation. Any unexplained use of diuretics. Why is the patient on a diuretic? Probably because they have heart failure. And a specific focus question on orthopnea or PND. When you examine the patient looking for rales, ankle edema, heart murmur, in a diabetic patient, also a very high risk finding, and then you look at the ECG and any abnormality, and by any I mean any, left ventricular hypertrophy, left atrial enlargement, axis deviation, non-specific changes is a very powerful marker of underlying dysfunction of the myocardium. At this point, if any one of these symptom signs or ECG abnormalities are present, do an NT-proBNP. And if it is abnormal, proceed to echo and a specialist consultation with cardiologist. If it's not abnormal, think of something else, but again, in this patient, it could be an anginal equivalent, as my previous speaker has said. So it is a very important tool in the non-acute outpatient setting in the diabetic clinic. And these are the cutoff points. They are much lower than what we use in the emergency room, 125 for NT and 35 for BNP. There is plenty of randomized clinical studies actually that showed that this approach for early detection of heart failure in the diabetic clinics led to early detection, early intensification with addition of renin-angiotensin blockers, beta blockers, and at this point, SGLT2 inhibitors, leading to early intensification, reducing cardiovascular death or heart failure hospitalization in these two large randomized clinical studies in diabetic outpatient clinics conducted by diabetologists, not heart failure specialists. So let's go to the focus on heart failure. So heart failure actually has two important phenotypes. So this is the normal heart. Here we have the hypertrophic heart, the patient with diastolic heart failure with preserved ejection fraction. The ventricle is not weak, it's not dilated, but it's thick and the LA is dilated. The more advanced form is the dilated cardiomyopathy, the systolic heart failure, ejection fraction is reduced, the ventricle is large, and of course can also have a stiff ventricle as well. The ESC heart failure definitions are very straightforward. If your ejection fraction is more than 50%, you can still have heart failure, symptoms and signs, but you will also have increased levels of natriuretic peptides, and you will generally have LVH or left atrial enlargement and diastolic dysfunction. If the EF is less than 40%, symptoms and signs exist, and the EF by echo is less than 40%, and there's this confusing group that's in the middle. In any case, even if the ejection fraction is not low, you can still have heart failure, and this is very common in diabetic patients. So this is the ESC guideline expanded a little bit. It's a clinical diagnosis, symptoms, dyspnea, fatigue, lower limb edema, ECG abnormalities. Chest X-ray is not mandatory because these patients don't have pulmonary edema. but the natriuretic peptides help you. And then the echo will be helpful to look for reduced ejection fraction, preserved ejection fraction, which is the common variant in diabetes, and also valvular heart disease and more rare variants. So it's very clear that these natriuretic peptides are a qualitative marker of heart failure. They are elevated when there's volume overload, pressure overload, and they help you to make the diagnosis, and they are prognostic and correlate with disease severity. And in fact, there is a specific page in this guideline from the European Society of Cardiology looking at this being done by GPs and diabetologists. It's really important. This is actually being applied in the primary care setting before they come to cardiology. Symptoms, some physical findings, ECG and natriuretic peptides, suggestive diagnosis of heart failure, echo, go to the cardiologist, and the cardiologist then has to look at the different phenotypes and how to initiate treatment. And what we can do in the GP and diabetologist setting, of course, is the use of SGLT2 inhibitors routinely and more frequently in these patients, plus escalation of RAS blockers such as ACEs and ARBs. So there's a strong recommendation, level of evidence to one, for natriuretic peptide measurements in GPs and diabetologists in high-risk populations, particularly diabetes and hypertension, to target initiation of preventive measures, up titrations of RAS blockers to prevent heart failure or slow the development of heart failure. And these again are the cutoff points. Less than 125 essentially rules it out. Above 125 requires additional workup, including echo and follow-up examination. So without going into the details, there's a lot of information about natriuretic peptides, which will require a separate seminar. And it's very important to think about this in the context of making a diagnosis with these vague symptoms in a high-risk diabetic patient, even if they don't have coronary artery disease. Now, heart failure is often the first manifestation of type 2 related diabetes, type 2 diabetes cardiovascular disease. It coexists, and we have seen in trials prevalence of heart failure from 10 to 30%. And actually in heart failure trials, diabetes is present in about 30% of patients. Now, there's a bidirectional association also with heart failure and CKD. A diabetic patient with CKD is twice as likely to have heart failure in this very large cohort of almost 640,000 patients from the United States. And having CKD increases the risk of heart failure by twofold. Having heart failure increases the risk of CKD by twofold. So if you have a diabetic patient with a reduced GFR or microalbuminuria, also think of heart failure as a target organ damage. Now, this data is very compelling and I think will be very interesting to you. So in these two studies, 68% of patients with asymptomatic 5 years of type 2 diabetes, no coronary artery disease, actually had LV dysfunction. 16% has diastolic, 27% has systolic, and 25% had both. A minority actually had normal LV function only after 5 years of diabetes. And in this other study using specific cardiac screening in diabetic patients, again without coronary artery disease, at least 30% of the patients had some LV dysfunction or some heart failure. So this is an early and forgotten complication of diabetes that we cannot afford to miss because of the powerful treatments we have right now. So diabetes also not only increases the risk and incidence of developing heart failure, but also increases the risk of bad heart failure, where the patients need hospitalization. And the risk is almost tripled after 3 to 4 years of diagnosis. And one very important factor that's different from coronary artery disease and diabetes is this important fact. In this large study where they followed almost 1 million patients, 270 patients with diabetes versus 1.5 million without, patients who had controlled A1C, blood pressure, LDL, and albuminuria still had a 45% increase of heart failure compared to non-diabetic patients. So there is something about diabetes that causes the promotion of heart failure in spite of risk factor modification with conventional therapies. Why is this happening? Heart failure can be caused by myocardial injury, commonly due to ischemic damage with activation of the RAS system. But also, we know now we have the diabetic cardiomyopathy. This is the heart failure with preserved ejection fraction causing microvascular dysfunction, fibrosis, myocardial stiffness and hypertrophy, And this is in the context of type 2 diabetes metabolic syndrome, and it's called inflammatory cardiomyopathy or diabetic cardiomyopathy. So we know that diabetics can get heart failure through atherosclerotic mechanisms due to accelerated atherosclerosis, and also direct inflammatory microvascular effect, which is independent and causes fibrosis. And the diabetic cardiomyopathy, to simplify for our non-echocardiographic colleagues, means that the heart goes from normal like this, which is highly elastic, to a thick, stiff, fibrotic ventricle, which still has a good ejection fraction, don't be fooled by that, but has a dilated left atrium, reduced elasticity, so it's unable to distend, and though it contracts quite well, and causes high filling pressures and symptoms of congestion. And this is a real thing from pathology. This is not something we invented on echo. This is the original study that was published in 1972 from autopsy specimens of diabetic patients without coronary artery disease, extensive dense perivascular fibrosis, very large myocyte hypertrophy, and intermyocyte fibrosis as well in a patient who has diabetes, died of heart failure with a normal EF and normal coronaries. So remember the symptoms of heart failure in your diabetic patient, and we have to be, as diabetologists, also a little bit cardiology and a little bit heart failure specialist. What is the main symptom? Reduced exercise tolerance, fatigue, tiredness, increased time to recover after exercise. These are early symptoms and are often missed or misinterpreted in the outpatient setting. So ask your patient, can you go up one flight of stairs? If they say no, it's either angina or heart failure. If they can't walk anymore, it's not because they're tired or overweight. It's probably heart failure as well. So I think these are really key clinical symptoms. And as I pointed out before, this is the direct link between declining renal function and heart failure. So the incidence of heart failure in patients with heart CKD, whether they had heart failure reduced or preserved, was almost double that in patients who didn't have CKD with whatever ejection fraction. And the presence of microalbuminuria with whatever phenotype of heart failure doubled the risk of heart failure itself, even if they had a normal ejection fraction or a reduced ejection fraction. It's worse, obviously, if you have a reduced ejection fraction. So think of these two biomarkers as additional markers of heart failure in addition to BNP. It's very important to attack heart failure before the first symptoms. So here is this patient who has stage A or B heart failure, diabetes prior to their first ACS. So if you attack them with proper therapy at this stage, they won't go through this progressive remodeling and death within 5 years. And this is where diabetes sits. It sits here in the high-risk patient without structural heart disease. It sits here in the patient with the diabetic cardiomyopathy. It sits here in the advanced heart failure patient, and it sits here in the end-stage heart failure patient who's also terminal. And really, this is the ACC guideline on this. The first two stages of heart failure are not clinically evident or mild heart failure, but there's a lot of comorbidities, diabetes and coronary artery disease, and early therapeutic interventions in diabetes, even before the appearance of LV dysfunction or symptoms, can reduce population morbidity and mortality of heart failure in the primary setting before they even come to this stage. And you know very well that the guidelines have shown that heart failure prevention and SGLT2 inhibitors is now acknowledged in primary prevention population, largely from the RCTs, but also specifically from the DECLARE study, which it had a very large primary prevention arm. And more recently also data from the Canvas study. So all of the guidelines, American, European, and even others, tell us that SGLT2 inhibitors are recommended to prevent heart failure in type 2 diabetes and atherosclerotic cardiovascular disease. And the ADA guideline, and this is from the previous one, not updated, but it still continues to be very clear that patients with ASCVD at high risk of heart failure, SGLT2 inhibitors are preferred. If a patient has heart failure or CKD, directly SGLT2 inhibitors are recommended. And of course, GLP-1 or SGLT2 if it's mostly ASCVD. Now, if you go to heart failure itself, we know that there's a lot of medications in the heart failure literature, ACEs, ARBs, beta blockers, MRAs, and valsartan sacubitril that help patients to survive heart failure. And now there's an extra line we add here for SGLT2 inhibitors. So to wrap up the idea of heart failure is a huge global burden with massive unmet needs. Heart failure is malignant as some of the most common cancers with 5-year survival less than 50%. Improvements in heart failure mortality still are not maximized because of lack of use of guideline medical therapy. And type 2 diabetes is a major factor for the development of heart failure. It's often early, often undetected in patients with type 2 diabetes. So we have to detect it in the setting that the patient comes to the endocrinologist and the diabetologist. And now, this is really the evolution of the SGLT2 inhibitors from heart failure prevention in diabetes to heart failure treatment in both diabetes and non-diabetes. And we have to thank our endocrinology community for introducing us to these really incredible drugs. So you know that the Canvas program, Credence, Declare, and the EMPA-REG looked at patients who had diabetes with early stages of heart failure. The clinical stages of heart failure with severe heart failure, DAPA-HF, DELIVER, EMPEROR, Reduced and Preserved, are now have published diabetic and non-diabetic data that is remarkable in end-stage heart failure. So the spectrum from prevention, early disease, to severe disease now includes SGLT2 inhibitors as a core medical therapy from prevention to treatment. And as you know now, because of DAPA-CKD and EMPA-KIDNEY, also prevention of CKD in diabetic and non-diabetic patients. The mechanisms are very, very fascinating and nobody can really explain them properly, but we believe that the natriuresis reduces blood pressure and plasma volume, preload and afterload, LV wall stress, in addition to the tubuloglomerular feedback restoration that helps restore the renal biofeedback mechanism. Natriuresis with SGLT2 inhibitors is actually seen with and without diabetes. In other words, it is independent of the A1C and glucosuric effect, which means we can use it safely in non-diabetic patients. And the important cardiorenal interactions in heart failure that this is blocked is prevention, we believe, of chronic inflammation, prevention of the acid-base metabolism, prevents activation of the RAS and sympathetic nervous system, and attacks the fluid overload and the vasoconstriction. So this whole package on the kidney affecting the renal blood flow and improved renal function and intraglomerular pressure, on the circulation, increasing the hematocrit and volume, on the myocardium, reducing preload and afterload and stress, and also myocardial energetics, which you know more than me about the ketone hypothesis and the sodium hydrogen exchange theories. So it is almost parallel to the RAS blockade, and it does have this very potent effect on improving kidney function and albuminuria. In addition, unlike loop diuretics, they selectively reduce interstitial volume with no change in the blood volume, and therefore limit the aberrant reflex neurohormonal stimulation in the setting of high-dose loop diuretics. So we get all of these benefits with the SGLT2 inhibitors, and I don't have to explain the mechanisms, but we also know from randomized clinical studies that this really works. So cardiac and renal protection and prevention was seen in EMPA-REG, Canvas, and Declare, the secondary prevention. In Declare with the multiple risk factors, primary prevention, reduction of renal outcomes, improvement of renal stabilization, reduction of heart failure, reduction of major cardiovascular events in primary and secondary prevention patients. Empagliflozin showed a 35% reduction in heart failure on top of standard of care in high-risk ASCVD diabetic patients. The Declare patients, majority actually did not have coronary artery disease. Most of them actually had mild CKD, and the majority had primary risk factors only, multiple risk factor group here. And we see there that in terms of MACE, it reduced MACE in only the patients who had a prior MI compared to placebo. But in terms of heart failure, it was very significant heart failure and cardiovascular death in all patients, whether they had a myocardial infarction or not. And in fact, this actually proved that, like empagliflozin, DAPA prevents heart failure in a type 2 diabetes population by a factor of almost 27%. And if you looked at the presence of prior MI or not, heart failure or cardiovascular death was reduced very consistently by about 20 to 25% with an absolute risk reduction, more in the prior MI patients, but still significant in the patients who had no prior MI. Now, this is fascinating because these three studies, EMPEREG, CANVAS, and DECLARE, are not heart failure studies. They are CVOTs. And in reality, less than 10% of patients in these studies had documented heart failure or EF less than 40%, meaning that most of these patients with type 2 diabetes were missed in having subclinical heart failure. And by pure accident of these patients being enrolled, they had a tremendous reduction of heart failure as their primary outcome, driving the positive events in the clinical studies. So you'll see here, this is very consistent from all the studies, right? This is DECLARE, MACE, reduced only in the patients who had prior MI, heart failure and cardiovascular death in all patients, renal outcome in all patients, whether they had an MI, whether they had stable CAD, recent MI, primary prevention without MI. So this is very powerful because we are now protecting two vital organs from heart failure and renal failure. And this is a class effect. All of them, EMPEREG, CANVAS, DECLARE, and even recently published VERTIS CV, if you have heart failure, if you don't have heart failure, it prevents it. If you have risk factors, it prevents heart failure. If you have MACE, it will reduce the MACE events, which are atherosclerotic events. But if you don't have MACE, it still prevents heart failure. So it's a remarkable, remarkable change in how we view these agents. And as I mentioned, really, in DECLARE, the minority of patients had an EF completed. And what does this mean? It actually means that most of these patients, regardless of their history of heart failure or ejection fraction, had a reduction of heart failure itself, whatever the ejection fraction was. So this is telling us we are missing the majority of patients, even in randomized clinical studies conducted by the world's leading experts in diabetes and heart failure, right? Because this remarkable difference cannot be driven by a small subgroup of less than 10%. So I'm just going to go through this very quickly, just not to waste your time. The DAPA-HF study included 50% of patients diabetic and non-diabetic, and on top of heart failure standard of care in patients with low EF, an additional 26% reduction was seen in heart failure hospitalization or cardiovascular death. And the the impact was very early. Within 28 days, death or heart failure was significantly reduced. Both heart failure and CV death were significantly reduced on top of medical therapy, and the diabetic or non-diabetic patients had an equal benefit. Low GFR, normal GFR, equal benefit. MRA, beta blockers in the background, equal benefit. Everybody seems to have a significant impact, addition of dapagliflozin in their heart failure treatment. And whether you looked at first event or total events, there was a significant improvement. So just to come up to this final thing, EMPEROR Reduced was also recently published, and it's very important to mention that. So they looked again at patients with low ejection fraction, standard heart failure. Again, 50% of patients were diabetic, 50% were not. And here again, we got a 25% reduction of heart failure or cardiovascular death by addition of empagliflozin. And if you took all of these studies together, EMPEROR Reduced and DAPA-HF, 25% reduction in heart failure or CV death. Only, however, DAPA-HF had a significant reduction of cardiovascular death with the addition of this to these therapies. So now, as I look at it from a different standpoint, patients with heart failure, reduced ejection fraction, now have many different options that help us save their lives, whether they have CKD or not, whether they have diabetes or not. You give them the beta blockers, MRA, ARNI, ivabradine, and SGLT2 inhibitors to give strong evidence of cardiovascular protection in every step of heart failure. And thank you very much for your time and your attention.
Thank you, Dr. Sabbour. I think it was wonderful and great learning for everybody in the audience. If I just summarize, which you have done very well, we should ask the patient. We are mostly ignorant about it. Even in asymptomatic, we should do an ECG. I don't know, would you recommend that BNP or anti-BNP, pro-BNP should be in the usual standard diabetes test profile? So these are comments which we'll ask. I've got a long list of questions. So first, I will just ask you for the 3 messages you would like to give to the audience to summarize your talk. Next, I will ask Dr. Zahid to give 3 points to summarize his talk, and then we will go into the questions and panelists. Thank you.
So three key messages. Heart failure is probably the commonest complication of diabetes, and we miss it all the time. The symptoms are dyspnea, lower limb edema, fatigue, not pulmonary edema, right? So they may have mild symptoms. Any ECG abnormality in a diabetic patient with risk factors has to be processed for further evaluation. So do an annual ECG. Add an NT-proBNP to your A1C or your lipid profiles. Have a liberal utilization of echo and referral to cardiologist. And the cardiologist also has to understand if they don't have coronary artery disease, they could still have diabetic cardiomyopathy. And thirdly, intensification of therapy. I believe that in addition to statins, SGLT2 inhibitors and RAS blockers are life-saving in the diabetic patient. And we really have to apply them broadly, extensively, and without any exclusion, and especially in the patient with CKD and diabetes, to consider the heart failure aspect and the renal protective aspect of both treatments.
Thank you. Dr. Zahid, your final 3
Oh, yes.
seconds message.
Okay, I mean, of course, we know that diabetic are high risk. I mean, you don't have to screen asymptomatic patients. That's the first thing. And my speaker very nicely said, but you can't, many people are symptomatic and we label them asymptomatic. So you have to, as I mentioned, shortness of breath, echo was normal. The most common cause of even somebody with new onset heart failure, you have to rule out ischemic heart disease. That's a message, because you have to look for treatable conditions, okay? Coronary artery disease, ischemia is a treatable condition, which is causing heart failure, is according to symptoms. You have to do the workup. And of course, you have to risk stratify, not every diabetic, okay? The history, other parameters, the basic medicine you have to practice. And you have to be less aggressive in low risk patient. And with intermediate risk patient, you need all the tests, okay, to classify them with calcium scoring and all the other parameters. With high risk, you know that they have to treat it aggressively.
Thank you, Zahid. Now I've come to the long list of questions and we may run out of time. So although Dr. Hani and Zahid have elaborated a little, Dr. Saeed Mahar, one question is about, should we give SGLT2 inhibitors even in patients who are non-diabetic?
Yes?
Yeah, Dr. Hani has already elaborated in his talk and shown the studies very nicely that it's not only the patients who are being benefited from SGLT2 inhibitors who are diabetic, but now this is actually the non-diabetic patients who has got the heart failure. These patients are being benefited from the SGLT2, and this is proven. And so I think so. This is very much now on the record that yes, the patients who has got heart failure, if they are non-diabetic, they can be benefited from SGLT2 inhibitors.
So one more question, interesting one, and I will leave it. Dr. Qamar can answer first and then others can input as well. If the patient is not overweight, normal BMI, would you still give SGLT2 inhibitor?
Yes, I would still give them SGLT2 inhibitors. So normal weight is not a contraindication for that. In my practice, I give it to the most of the diabetic individuals unless there is a contraindication. And the contraindications to me are, up to up to 25 or 28 of creatinine of EGFR, I still use SGLT2 inhibitors. Somebody have recurrent urinary tract infections or recurrent balanitis. Those are the symptoms, or recurrent vulvovaginitis. Those are the patients that I refrain from giving them. Even on first UTI to a female, I would hold it during the UTI, but I would still continue for it. But if somebody have like 2 or 3 UTIs in 1 year, I would avoid it. But normal weight individuals, I would give SGLT2 inhibitors.
So Dr. Hani, any comments?
So I mean, I have to disclose something. I am myself a type 2 diabetic. I am myself on SGLT2 inhibitors. And I think this is really important. We have to recognize that these drugs are not for A1C. These drugs, for some reason, yani God has given us this miraculous intervention that helps the heart, helps the kidney, and also gives us HbA1c. And we've actually had a lot of discussions with our nephrologists, actually, and they are fully supportive of using the SGLT2 inhibitors for renal. There's initial that hyperfiltration stage, and then the kidney function stabilizes for years. So I think this is even an additional benefit that we weren't recognizing. So
You are for it. I will just give a comment from my side. There are some patients where I had to stop the SGLT2 inhibitor because they were losing weight a lot. And I think there I got the message from you, or more so from Zahid as well. We have to look into whether they need it. So if there is nothing to suggest heart failure and they are underweight, I won't give it. There was another question coming from the panel as well. So GLP-1 versus SGLT2, we are all strong believers, but I am open to, so at this point we have got two experts, an atherosclerotic, he's expert on everything, but he talked about the atherosclerotic disease where we will go for GLP-1, and you are the one who are looking at the heart failure, so you will go for SGLT2. For our young diabetologists, give us the message, what should they do? They are not experts. You can say start both, but that's not possible usually. So first to Zahid, GLP-1 versus SGLT2.
Yeah, I mean, it's very difficult, tough question. So, I mean, of course, I mean, we'll go for SGLT2, more of a preferred.
I think I can go to the diabetologist because they are handling this question every day. So,
Yes, sure.
Dr. Qamar Masood, where would you go for it, GLP-1 versus SGLT2?
You know, in our scenario in Pakistan, SGLT2 inhibitors are, you know, in a very economical price, and it's generally very well tolerated. We counsel them earlier that for first week or so, you may feel a little bit more frequent urination. For, you know, GLP-1, it's difficult to, even if you tell the patients all the benefits, it's difficult to convince the patients. In high-risk individuals, in patients who already have underlying coronary artery disease, we try to give them. Sometimes it's difficult to tolerate, and it's expensive. And sometimes, you know, even after a year, they say we don't get any much benefit from it because. I mean, I would go for SGLT2 and patients who already have underlying coronary artery disease. Some patients with high risk, I counsel them, I try to give them, but I think I'm not very successful in that.
Dr. Saeed Mahar?
Yes, sir. Absolutely agree that, as Dr. Qamar has said, in our part of the world, there are two things which really we're not convinced sometimes with the patient. One is the cost, as the GLP-1 is expensive, and second one is the prick of the needle. So looking at the things, the patient is very convincing and encouraging to take the pill, which is the SGLT2. So SGLT2 is easier for the patient to take, cheaper than the GLP-1. But in some of the patients who has got advanced cardiovascular disease, very obese patients, then sometimes you give both the SGLT2 as well as the GLP-1 to some of the patient, including with the metformin, and they've got very good results. But this is not for every patient.
Thank you. Dr. Hani, you disclosed that you are taking the medicine. Somebody asked a very important question. I'm not really asking what are you taking, but the question is DAPA versus EMPA.
So this is a very difficult question to answer. I knew it was going to happen. So right now we have a lot of evidence, right? We have to apply the evidence based on the clinical studies. Now, logically speaking, you have the DECLARE outcome study included a very large primary prevention group, multiple risk factors, hypertension, diabetes, dyslipidemia. And I think you can easily apply this to the primary prevention setting that you all practice in. We also have an additional benefit in a patient with only myocardial infarction that we see in the EMPEREG outcome study for patients who have had a prior MI. So that's the secondary prevention group. So I don't really know how to explain this. Now, in the heart failure literature, it's actually different, and I don't know how to explain it on the basis of study design. So DAPA-HF had an all-cause mortality difference, which we know specifically is the king of all outcomes. EMPEROR reduced did not, and there's been a lot of editorials and comments about the study design and whatnot and so on. But I would say that if I have a sick heart failure patient, I'm going to give them the most powerful agent that I can, and that is at this point DAPA-HF. Now, with that being said, between the two studies, there's a difference in the background therapy. There was more use of Entresto, more use of ICDs, and maybe that sort of attenuated the effect of EMPEROR. So I don't know why it works in one as more than the other, but the class effect on heart failure prevention, which is what concerns most of the diabetologists, endocrinologists, GPs, and primary care and cardiovascular preventionists, is something that is very broad and very powerful.
Thank you. Zahid, one question for you. So,
Yeah.
you elaborated on that, when should I decide? Because, you know, most of the diabetologists, they don't do the risk scoring. And they are sitting in the clinic and I see the patients, one is coming who is on aspirin, the other is coming who is not on aspirin. And if I don't do the scoring, how do I decide which one is the right way to go? Give aspirin or not to give aspirin?
Right. So, I mean, if you quickly take the history, if somebody's age is above 50, okay, and if they're more than one risk factor, okay, so you know, I mean, you don't have to risk calculate, okay. The problem is giving aspirin to a low risk group. So, where there's a problem, giving aspirin to all the diabetic, yes, most of the very few diabetics you will find have only diabetic with no additional risk factors. So, it makes it easy. Somebody's above 50, history of more than 10 years, longer diabetic, okay, and more than 1-2 risk factors, you know, you don't need any calculator.
Great. So this is the message I will record. I was just writing down and I wrote down exactly the same thing. More than 10 years, more than 50 years, give aspirin without asking Dr. Zahid. Should I send to you this patient or do an calcium score or not? Because calcium score is costly.
It's not very expensive in our part. Okay, it's for patients love it. They think they are getting CT angiography actually.
You have to do, yeah, but you have to
And
do
they will
CT.
ask me whether I need a bypass or angioplasty. So it's a good test in intermediate group, not above 60. Okay, because already high risk, the calcium load is already above 60. As I told the example of my friend's brother, he ordered CT calcium score. It was high. He's 66, 65-year-old. What to do about it?
That's where my question is. You say intermediate score. Most diabetologists don't do the scoring.
Right. Above 60, okay, there's no point of doing calcium scoring. Okay.
Good. Very good. Message coming. So before I hand over to Amna for concluding remarks and thanking our speakers, any final last minute comments from both the speakers or panelists? It was wonderful learning for me.
I think there were some concerns about screening people with BNP, and I'm going to tell you really the value of using the clinical questions and the ECG. In our setting, the ECG costs less than 60 dirhams, and the NT-proBNP is about 200 dirhams. An echo, on the other hand, is 2,000 dirhams. So using those two tests, you can filter out the patients who need the echo and those who do not, right? And I think it's very important in the clinical practice of diabetes, as we do eye exam every year, foot exam, renal function frequently, to really include some assessment of heart failure, whichever one you pick, and make this a routine investigation for your patients. Because it's so common, it's not funny. When we start doing these BNPs in these patients and looking at their ECGs, you will be surprised as how much there is. And I know obesity contributes, and I know this deconditioning contributes, but don't assume that. Look for it. If the BNP in ECG is normal, fine, you're generally off the hook. But if it's not, here's a red flag, right?
Oh, that gives me a great message. And I think if these two are normal, I won't send the patient to cardiologist. Agreed?
Yeah.
Great. Any more comments? Thank you. So hand over to Amna.
No, not from me.
Yes, please come ahead. Go ahead. Any? Okay, Amna, hand over to you
Okay.
because
Thank
your
you so
comments
much.
are welcome as well. Anything you can.
Thank you so much. It was very informative. Both sessions, both talks were very informative. And we learned a lot, especially in the question and answer sessions. We got many queries solved. And they were very practically important answers that we got that we face every day seeing the patients. So thank you so much, everyone. It was a wonderful session, very informative. And thank you, PES, for letting us be a part of this wonderful academic activity. And have a good night. And Allah Hafiz, everyone. Thank you, sir. Thank you, everyone.
Allah
Hafiz,
Hafiz.
Allah Hafiz.
Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you. Okay. Allah Hafiz.